All right. Hello. Welcome, everyone. We'll give you a moment to kind of come in the room and get settled, maybe get something to drink, get comfortable, and settle in for us for a little while. My name is Julia Wood. I'm the Director of Professional and Community Education at the Lewy Body Dementia Association. And you'll notice here on your screen that we're winding down, but this is kind of the tail end of Lewy Body Dementia Awareness Month. And so I'm so glad that you could join us today to learn more about this. It's estimated there's 1.4 million people living in the United States with Lewy body dementia, and we hope that no one faces this alone. And I'm also certification and training faculty for LSVT Global. And so this has been a partnership we've had now for, I think, about 3 years or so of LSVT Global really partnering to help our clinicians and also our community members understand more about Lewy body dementia. All right, so today our topic is going to be seeing clearly with Lewy. So, how LSVT Loud and LSVT Big treatments can help you communicate and move better. And we're going to be talking about some of the visual issues with Lewy body dementia that sometimes need to be adjusted around and adapted to for you to really be successful with those strategies. So I will be one of your presenters today. I'm an occupational therapist by training. I've been an instructor with LSVT Global now since I believe 2018. My counterpart today is going to be Dr. Jessica Galgano, who is a speech language pathologist and has joined us too. So you're kind of getting a couple of different perspectives on this. And so to tell you a little bit about myself, I'm an OT who specialized in treating and assessing people with Parkinson's and related dementias for a little over around 10 years, actually, at the University of Pennsylvania's Parkinson's Disease and Movement Disorder Center. During the pandemic, I transitioned to a role at the Lewy Body Dementia Association to really focus on education for this population. But I serve as faculty for a lot of courses for the Parkinson's Foundation. I work on subcommittees for the World Parkinson's Congress, and wrote a practice guideline. So if there's any OTs out there and you're looking for more information on Parkinson's, that's a great place to start. Dr. Galgano, who's with me today, is has a doctoral degree in biobehavioral sciences from Columbia, and she represents speech and also LSVT often at national and international conferences. And she's authored and co-authored publications related to neurologic communication and voice disorders. She's a faculty instructor at NYU Langone School of Medicine, and she is the CEO of Open Line Speech and Communication, where she provides LSVT, loud, and other types of treatment to adults and children. So she's also an executive board member for the Academy of Neurologic Communication Disorders and Science, is a clinical expert and faculty member and workshop leader for LSVT Global. So thank you for joining us, Dr. Galgano. All right, so we'll be hearing more from her a little bit later. These are our disclosures, so it's important to note that Jessica and I both are a little biased. We definitely have a preference for LSVT loud and big as treatment techniques, but also we are consultants and do receive lecture honorarium from LSVT Global. So our logistics, just to kind of give you the overview today, your microphones are muted. You can type your questions into the chat or into the question and answer box that you'll find on your toolbar. There are some handouts that you'll notice are available for you to download from the chat, and you might have received those in email as well. There is a survey that will come up at the end of the presentation today. We really appreciate if you can take time to fill out and complete that survey, because that helps us understand what you liked about the presentation, maybe what could have been done differently, and topics that you might be interested in for the future as we're planning for 2025. And then also we'll talk here about continuing education units as well. So this global is not state registered for CEUs, for speech, physical, or occupational therapy. But if you would like to self-report the activity, you can email webinars@lsvtglobal.com and request a certificate of completion. And you can use that to self-report. And also, you can view this as an on-demand webinar and email to get that survey to be able to complete and get credit for that as well. So, our learning objectives for today is that we hope you'll be able to summarize some of the visual perceptual challenges and vision issues that we see commonly in Lewy body dementia. We want you to really identify methods to prioritize your visual health because we don't think about that a lot when we're talking about Parkinson's disease or dementia, but it is really critical and a very key factor. You'll be able to list 3 features of LSVT BIG, which is an application for physical and occupational therapy, and also LSVT LOUD as it relates to speech therapy. And so you'll be able to also highlight some strategies to address visual challenges that you might be having. And this could be in treatments that you're receiving, but also throughout your daily life as well. All right, so let's get going. So I'm going to launch a polling question here so we can find out a little bit more about who is with us. And for some reason, I'm not seeing polls here. Oh, there we go. I found it. Sorry about that. Takes me a second. Now I'm launching it. So we're wondering if you are a person with Lewy body dementia or maybe another type of neurological condition. Are you a family friend or a care partner? Are you an LSVT Loud or LSVT Big certified clinician? Or maybe you're a certified health professional or student who's not LSVT Big or Loud certified. All right, so let's kind of see what we've got here. Just give you a couple more seconds to kind of fill this out. All right, so it looks like everyone, or people are still answering. We'll give you just a little bit longer here. All right, looks like everybody has completed it that is interested in it. So I can kind of share the results here. So you'll notice we've only got about 4% are people living with Lewy body dementia, but then we've got 15% of you are family or friends or maybe a care partner for those individuals. We've got about 42% of you are LSVT Loud or LSVT Big certified clinicians. Thank you for joining us. We had a professional version of this webinar last night that you'll be able to watch on demand soon. And then we have about almost 40% of you are non-LSVT certified health professionals or students. And we're really glad that you're with us as well. All right. So with that, we'll move along with our content here. So we're going to start out, and I'm going to do a quick overview here, but I really want you to understand more what Lewy body dementia is and what the associated vision changes are that we see, and kind of how we'll talk a little bit about how it's different from other types of dementia too. So this is what we call our umbrella for Lewy body dementia. Sometimes people will describe this more as a spectrum, but this nomenclature and this naming of this people find confusing a lot. So we'll start in the left-hand corner of your screen, and you notice you have that little purple square, and it has a little thing that almost looks like an egg of some sort, and then there's this like brown blob inside of it. So that brown blob that you see is a Lewy body. And that is just a clump of that misfolded alpha-synuclein protein that we think of when we think of Parkinson's disease and these types of dementia. And it is in the neuron. So you think about these, neurons and their jobs to really move neurotransmitters. You could see where having this big clump of protein is like blocking up the highway. It's like a traffic jam. And so it can really inhibit the ability of these neurons to communicate and send signals. Now you notice under our umbrella, Lewy body dementia actually includes 2 types of dementia. And really, these are the same pathology. They still involve those Lewy bodies. The difference is just when the symptoms present. So in the case of Parkinson's disease dementia, the Parkinson's comes first. So you can think of it like a chicken or egg. So those movement symptoms are going to happen first, right? This is somebody who's had well-established Parkinson's disease. So maybe that slowness and shakiness and stiffness for at least a year before they start to have dementia symptoms. And we know that for people with Parkinson's disease, the studies suggest around 50 to 80% of people will go on to develop Parkinson's disease dementia over time. So this is very common. In the case of dementia with Lewy bodies, the timing is flipped. The dementia happens first or at the same time that the Parkinsonism starts. And then for some people with dementia with Lewy bodies, what's interesting, they have those cognitive changes first, and then some of them never develop many movement changes, but some do. So this is where we see a lot of misdiagnosis, a lot of misunderstanding. And it's important to note too that this is what we call the 1 year rule, right? So we're thinking about, do the movement changes happen within that first year? Does the dementia happen, which just means their cognitive impairment is impacting their daily function and their daily independence? That's really all we're talking about. So this is hotly debated a lot of times. Is they're actually the same thing? It's just a different time they present. So however you view it, when we're talking about Parkinson's disease first, we're looking at PDD. For those folks with DLB or dementia with Lewy bodies, those cognitive changes happened first or at the same time. So this is very, very different from Alzheimer's disease, you guys. And this is where I think some confusion comes in play. Even at tables, a lot of times when we're tabling at Parkinson's types events, people will see my Lewy body dementia sign and be like, oh, glad we don't have that. He still remembers all the grandkids' names. Well, for the most part, they likely may always, that won't be a problem. And so these graphs demonstrate why. So if you look at the graph on the top, that's Alzheimer's disease dementia on the side, right? And so all these colored bars that you see going across are different measures of cognition. So these are neuropsych batteries. So if you went to see a neuropsychologist to do a really in-depth look at your cognitive abilities, these are different tests that they might be doing. On the bottom, people with dementia with Lewy bodies completed those exact same tests and assessments. So let's take a look at it first and ask yourself, do these graphs look similar, different, or opposite? To me, when I look at them, I really feel like they're opposite. And except for, you'll notice on the far left side, that black bar down the side that says global below it and has a DRS, it's a dementia rating scale. Notice where we're looking at the scores on the side there, it's the same, right? So if someone with dementia with Lewy bodies goes to, say, a primary care provider or just gets a screening, just a global screening, often you can't tell it from Alzheimer's disease. But that's where the similarities end. When we move across to the right to those red bars, notice up top are folks with Alzheimer's, how low those scores are. Compared to on the bottom, those folks with Lewy, the scores are much higher. So memory, especially more long-term memory, right, of your family, your friends, where you grew up, things like that is not really going to typically be impacted. We move over to those green bars, those are measures of language. Notice how the one that is higher in the center for Alzheimer's is lower on the bottom for Lewy and vice versa. So even though we see more language difficulties typically with Alzheimer's disease, they're different. The types of language impairments we see vary. Moving over to those yellow bars, those are measures of attention and executive function. Once again, notice how high those scores are. The top for those folks with Alzheimer's compared to on the bottom, those folks with Lewy. If you think about attention, right, this can feed into working memory. So some of you at home might be going, oh, no, that's not true. I know I've seen somebody with Lewy that had memory problems. Well, if you're not able to attend to something, that working memory, right, is going to be impacted. So remembering something in the moment, but very different than in Alzheimer's when we're having really those long-term memories impacted. And then lastly, those blue bars that you see for visuospatial function, notice how high those are for folks with Alzheimer's at the top. And then on the bottom, how low those scores are for folks with Lewy. And that's a lot of why we're here today having this conversation is we're going to be looking at all the ways that vision really can impact daily activities, mobility, safety, all of these elements for someone with Lewy body dementia. So we're going to start and talking about vision in the brain. And a lot of people, a lot of times we don't realize we think of our eyes more related to vision, right? But really the processing of it happens in our brain. So a quarter of our brain is dedicated just to processing visual input. Another 25% is dedicated to interacting with visual regions of the brain. So you'll notice here we've got like 50% of your brain is either processing information or interacting with these regions that process. And so this is where we may recognize people, objects, and places. So a lot of times you may notice that people with Parkinson's disease or Lewy have a lot of issues with misidentification of people, misreading emotions, things like that. Also, creating memories, our vision is part of that. Performing different tasks with our hands. That could be something, as mundane as buttoning your shirt, or maybe it's doing scrapbooking, crocheting, meal plan, things that you are cooking, things you really enjoy. Also, these skills are involved in wayfinding. And that could be within our home, finding our way from our, kitchen to our bathroom or from our bedroom to our living room, all the way into like wayfinding in the community. So routing, knowing how to find our way back home or to different targets we're trying to find. And also avoiding hazards. So recognizing these different hazards, tripping hazards, maybe safety hazards in the environment. So our vision is involved in so much of what we do day to day. These studies were really looking more at vision and Parkinson's disease, but like I said, it's the same pathology. So a lot of what we see with vision and Lewy is very similar. So impaired oculomotor or eye movements. So the eyes being able to move and coordinate and scan. So you could see where this could impact reading or different issues that way. Also, dopamine is part of our color vision system. So, that loss of dopamine that we see with Parkinson's can impact color perception. So, it's really the same thing as color blindness. Colors may just look more dull or more faded. And from that, we can see decreased contrast sensitivity. So being able to see things in our home, like where a step begins, or a change in flooring, or maybe the coffee table, like, really seeing items on top of it if we're having issues with contrast sensitivity. And then that can also relate into figure ground. So being able to look on that coffee table that's busy and has a lot of things going on and pick out the item that we're looking for. We also see depth perception impairments often, which can lead to safety concerns on stairs or walking downhill, things like this. I mentioned that impaired recognition of emotion and faces earlier, but sometimes motion too. A dear friend of mine with Parkinson's disease dementia one time thought that there was a spider in the bathroom, and it turned out it was a leaf on a plant. And the way the heater vent was blowing on it, it made it look like it was moving a little bit. And so he was seeing that it was actually moving across the floor. We see impairments in peripheral vision. And sometimes there's a phenomenon that goes along with this too, where people perceive a presence, like someone or something is just behind them, just out of view. And when they turn to try to see who it is, that image is lost. This can vary with on off fluctuations with medications. So, my dear friend with Parkinson's disease dementia, things often feel, he said, like they're much closer to him when his meds go off. But when we think about Lewy, we also see these cognitive fluctuations as well, where someone's attention and alertness and arousal can really vary moment to moment, minute to minute, hour to hour, and that can impact as well. And then this all unfortunately relates into a lot of the issues we see with gait disturbances, so trouble walking, postural instability, so balance, freezing of gait, issues with that. So we can't really underestimate or overestimate, I think, enough how important vision is to all the things that we need to do in daily life. So These are kind of invisible symptoms if you think about it, right? A lot of times, this is a great slide that was done by a volunteer of ours named Helen Bundy Metzger, who had a father, sister, and brother all with Lewy, and her father was an optometrist. So she really lived in a world of vision and has lived in a world of Lewy. So, a lot of times with depth perception, we see a 3D object where they're really experiencing more of a 2D object. That color contrast, and we talked about kind of that color fading a little bit. That bush with bright red berries now just kind of looks a little grayed out. And the peripheral vision, a lot of times we might see a decreased kind of field of view of that when they're trying to look to that peripheral vision. And then double vision can often happen for people with this condition, and they may need that treatment, some treatment for that that we'll talk about in a little bit as well. So important to note here that, Louis really going to impact the visual system by interfering with the ability to process and also respond to visual information. And it's important to note that these symptoms often occur very early in the disease, but they're usually not noted until the later stages. So it's something to really be aware of and start to address early on with your healthcare team and care providers, before, safety issues are becoming more of a concern. And it's important to note too, we'll talk about this a little bit later, that visual hallucinations really occur early and persist throughout the course of the disease. And these can be very upsetting and disturbing for families as well. So, how do we identify visual brain dysfunction, right? You're going to an optometrist, they're looking at the eye, and this is definitely not part of a routine eye exam. It's not something they're really going to look at. So, really assessing this requires specialized testing and assessments. So, this is typically going to be a neurologist or a neuropsychologist, and is done during different types of cognitive testing. Can also be screened by an occupational therapist. A lot of times we'll do different clock drawing tests or different tests of visual perception. So those are kind of, I'd say, your top performers. You can also consider treatment by a neuro-ophthalmologist. And so this is a neurologist who has some ophthalmology training, and a lot of times they can really tease out these visual brain issues as well. So how does this impact daily life? Well, often people will set items, right at the edge of a table or surface, or they might think that items are much closer than they are. Early on in my career, I had a gentleman who was having trouble unloading the dishwasher without breaking dishes because he really couldn't clearly see where the dish was when he put it in the cabinet, or how close it was to the edge of the counter. And a simple fix of just using some colored shelf liner and like a brightly colored placemat helps him have a visual target. Another very common issue that we see is when someone approaches a chair to sit, they'll start to reach prior to getting to the chair, and you'll see sometimes even maybe some freezing or festination with their walking, and they're really having trouble determining how far away from that chair they are. And then we also may see some challenges, in the home or community, maybe bumping into furniture and walls at home. But maybe if you've got a shopping cart, out in the public, maybe having some trouble navigating around those center aisle displays. You might have taken some of those out. And then when we think about other things with daily life, I mean, driving early on can become a real problem. And this sometimes is not just actually driving a car, but for some people, even riding in a car. I had a patient at one point who really had to wear almost like these, like those sleep, sleep, like a blinder on, because she was so convinced, because of her visuospatial deficits, that cars were about to hit them, that it made her very anxious and very nervous, even when her husband was driving. And then people can have significant challenges, of course, to any of their daily living activities. When we think about all the things involved in dressing or grooming, trying to shave and get maybe hard to reach areas, maybe with bathing, telling the shampoo from the conditioner, issues with mobility and walking around the home and safety resulting from that. And then also early on, another element are these instrumental activities of daily living where we'll have trouble, with cooking, with bill pay, home management, and reading. And that can be partly visuospatial function. And then some of the other cognitive challenges like executive function come into play with this as well. So one role that we can all play and something everyone can focus on is making sure that your eyes are as healthy as possible and prescription lenses are kept up to date and appropriate for various points of focus. So I know that, having Parkinson's disease or Lewy can really involve a lot of medical visits, but it's important to keep up your annual visits with your ophthalmologist or optometrist, even if you think your glasses are the proper prescription, because those changes that occur inside the eye, a lot of times really go unnoticed. So we want to make sure we're keeping consistent assessments. When we talk about that convergence insufficiency, a lot of times, people will have a hard time. Maybe these are movement disorders, a lot of times, right? So we have tiny little muscles that coordinate the movement of our eyes so that they can get that focal point coming in smoothly so that we're not getting double vision. And if convergence insufficiency is causing a problem, a lot of times the eye provider can provide prisms to reading glasses to help improve near vision. And it's important to note that people with Lewy often have trouble using a multifocal lens, like a bifocal or a prism, because of the need for the eyes to really adjust around that. So, multiple pairs of glasses a lot of times are needed for different tasks. So, it's important to seek out those proper lenses as soon as these visual symptoms become evident, and so we can keep people reading, keep them safe moving in their home, but really important to keep up on your eye care. So, talking about these prescription lenses, of course, not all medical providers and healthcare providers are aware of Lewy body dementia. And so, a lot of times, we might have to help educate those providers about needing corrections for different distances, how you might not be able to wear a progressive or a trifocal. This might be difficult. And, if you have that slowing to those eye muscles, different multifocal point lenses can be difficult to use. So if your eye provider starts recommending, like, oh, I think you need a progressive lens, you might be like, I'm not sure if that's really going to work with the changes that are going on with my vision with Lewy body dementia. So, and try to provide some education for them. We have a great resource at LBDA on visual function that you can share with your eye provider if helpful. Dry eye is often a problem too, and this can even mimic, double vision and blurring just because the eyes become so dry. And a lot of times this is caused by infrequent blinking. And we can do some simple things, to really help at least keep the moisture up in the environment and help kind of guide you toward conversations with your eye provider. So you'll want to talk to your doctor. Maybe you can use some artificial tears to really help keep the moisture up. Humidifiers can be great in your home, especially in a dry climate. Also, something nobody likes to hear, but staying hydrated, drinking plenty of water is important to maintain that tear film as well as the health and maintenance in our bodies, too. There are eyelid scrubs that can be done to keep the oil glands working properly. And then you can also talk with your eye care provider, with your doctor, to see if any of the medications that you're on are maybe impacting that dry eye, if there's something you can do about it. So, with that, I'm going to invite my colleague on, Dr. Jessica Galgano, and she's going to talk with you about the strategies that we can really use here for these visual changes. Jessica.
Thank you so much, Julia. Welcome, everyone. It's a pleasure to be here with you this afternoon. So now we're going to talk about the strategies that we can use, some more strategies to help with these visual challenges so common in Lewy body dementia. First, I'm going to introduce you to the LSVT BIG and LSVT LOUD treatments that will help with movement and coordination and communication, and that these can be adapted for visual difficulties. Then I'll talk about some specific strategies that can be used during treatment and in your daily life. So what you see here are the LSVT loud treatments, and these are very interprofessional interventions. And so We mentioned LSVT LOUD and LSVT BIG, and these are therapy programs that are evidence-based and have been shown to be effective in the treatment of different movement difficulties, communication, and swallowing difficulties in different neurologically affected populations. So, with regard to speech therapy, speech therapists or speech pathologists will typically target motor speech or the physical aspect of speaking. They might target voice and respiration or the coordination between breathing and voice. We may target swallowing, airway safety, but also the oral stage of swallow, which is also important to that pharyngeal airway safety. And we sometimes even work with esophageal motility difficulties as well. Importantly, with people who have Lewy body, cognition, working with executive function, and facilitating attention and memory strategies to be able to function day to day more easily is also a focus of a speech pathologist. And then again, we are certified, not all of us. You want to make sure that the speech pathologist that you're seeing is certified currently in LSVT LOUD, but this has been shown to be an effective treatment in managing some of those communication difficulties secondary to Lewy body. And then, with regard to physical therapy and occupational therapy, these two disciplines and professionals both are certified in LSVT BIG, and you'll again want to make sure that your PT or your OT does hold current certification in LSVT BIG. But PTs are really going to focus a little bit more on overall gross motor mobility, gait. They're going to manage and help you deal with the risk of falls. And then again, they're going to use LSVT BIG to manage all of these different difficulties that are associated with LBD. And then when it comes to OT, now we're bringing that movement into function. And so a lot of occupational therapists will function on helping individuals more easily and efficiently handle those daily tasks that we all have to deal with every day. They'll also manage mobility and safety issues. OTs also tend to work on cognition, possibly from a slightly different aspect. And again, they are certified in LSVT BIG or should be certified. So now let's talk a little bit about what is unique about LSVT BIG and LSVT LOUD. So Lewy body dementia, as Julia mentioned, is going to make movements slower and smaller. And in terms of voice, how that affects it is that those smaller and slower movements then make voice softer, and that can make speech less clear. LSVT therapies then counteract this by training amplitude, by training those bigger, normal, typical movements and a louder, healthier voice. So one might go from speaking with a more quiet vocal quality, right? And there's a less, you have to pay attention more, don't you, right now? And if I just think loud, I might feel like I'm talking too loud because I was just very quiet for a few minutes. But then I'm getting used to it, and using this typical amplitude of movement results in that typical loudness. And so that's just a quickie little demonstration of how that small movement pattern presents itself, and then what that big amplitude focused shift can make happen. So LSVT therapies consider not only those motor symptoms that people are struggling with, but also those non-motor symptoms that are very common to people with Parkinson's and Lewy body dementia. Fortunately, the with regard to the LSVT loud therapies, those non-motor symptoms, oof, they can be the toughest and the scariest to kind of deal with because they involve cognition and attention and how you're seeing things. It involves anxiety and depression and mood and the impact that being anxious or fearful or down can have on your ability to think straight, to organize your thoughts and express yourself clearly. And that's what I really love about LSVT Loud and LSVT Big, though I don't do that personally. It really helps handle all of those issues, not just movement, but non-motor as well. Unfortunately, these therapies are one-to-one. They are individualized trainings to work on things that matter the most to the person receiving treatment. So there are three key factors when we want to think about LSVT loud and LSVT big and how they're different from the traditional therapies that might be available. And so the main takeaways is that the treatment target is focused on amplitude. So in LSVT big, we are training big movement, typical amplitude of gross and fine motor movements. But if we only did that once a week, twice a week, 30-minute sessions or 45-minute sessions, it's not going to have a big impact. And we know this because back in the 1980s and the 1990s, there were publications, and the belief was at that time that therapy for people with Parkinson's didn't work. But that was because at the time they were only doing therapy once or twice a week for short duration. Once the LSVT globals were developed and designed and researched and more further refined and developed and applied, what we found was that the intensive mode of therapy was an essential factor in the success of these treatments working. So with LSVT loud and LSVT big, the mode is intensive with high effort, both within the hour of treatment and across the days of treatment each week. But then again, if we targeted amplitude and we did it intensively, it works really well, but we've got to make sure that people are calibrated so is long-lasting success. And there isn't just therapy that works in the therapy room and then leaves as soon as you walk out the door. So these are therapies that are designed to help kind of recalibrate that person. Think about when a scale is off and you have to kind of reset that zero so it's giving you that correct weight. The same thing happens for people with Lewy body dementia and these difficulties, these neurological difficulties, because many times what is perceived as typical is small and quiet. And then when individuals are moving around with typical movements and speaking with good loudness and clarity, it feels like they're going too big and looking crazy and talking too loud and shouting at people. So, what we need to do as therapists, when you're looking for therapists, families, and individuals living with Lewy body, make sure that the individual or the therapist you're working with is really from day one working on that calibration, helping you get comfortable with feeling too big and feeling too loud, even though you're at typical movement amplitudes and volumes. So, this is essentially the overarching concept of the target. And I want to briefly talk about the target, the amplitude, and calibration again before we go more into the different adaptations we can make for visual difficulties in Lewy body. But essentially, again, our target is amplitude. One of those main factors or underlying characteristics of Lewy body is a reduced amplitude of movement pattern or hypokinesia. And so what we target is in LSVT loud when that voice is too soft and movements are too small. In fact, do it for me right now. I know your microphones are muted, but say, "Good afternoon, Jessica," in a kind of a typical voice or a quieter voice. What you're doing there is not taking too big of a breath in. Your vocal cords are closing in a particular way or not really closing. And your mouth may not be opening so wide, the tongue, the articulators may not be um, hitting the precise contacts. But when I ask you to just think loud, right, and go, "Hi, Jessica," with some nice loudness, what did you automatically do? You took a deep breath in. You closed your vocal folds more. They vibrated more efficiently and effectively. There were stronger signals going from the brain to the muscles. You opened your mouth wider. You moved your tongue more. You moved your lips more. Out came clearer, more audible speech that was with good loudness. But what's important is that there was one cognitive cue: think loud. I could have told you to do those million things, but I didn't need to. This amplitude target hits them all. And the same thing holds true for LSVT big. We have a single target that triggers activation across the entire motor system. So people go from moving small to being big and moving with healthy amplitude of movement. So now let's talk a little bit about the mode of treatment that I mentioned just a minute ago. Intensity is first across the days of the week. And so we have 4 days a week of those 7 days of each week. So it's 4 out of 7 days a week, but it's only for a month. We do it for 4 weeks in a row. So there are 16 sessions, and that's minimum dosage for efficacy. These sessions are 1 hour long. Don't let people shortchange you. 45 minutes is not enough. We want 60 full minutes, a full hour of treatment each one of those days. Make sure that you are in one-to-one individual therapy. If you are receiving LSVT LOUD or LSVT BIG, it is not within a group. Though sometimes LSVT LOUD and LSVT BIG graduates do join LSVT LOUD for Life or LSVT LOUD for BIG or BIG for Life groups. These are really great maintenance groups that are exercise and lots of exercise, lots of fun, and different practices run those groups for their graduates. But also LSVTGlobal holds these classes for people for a subscription. So those are great ways to be in a group and have a lot of fun. But what you first want to do, no matter what, is get it one-to-one for you yourself, because that is really where you're going to get the most impact and have the most functional improvement. What's really, really important also is daily home exercise and carryover. That is essential. In fact, I have a client now who's been working with me, and she had said she had fallen off her exercises, and then we purchased the LSVT coach for her, which is a biofeedback system and a software that you can install on a PC. And that helped her do those exercises more consistently each day. And boy, within weeks has she had a big impact. So that daily home exercise that is recommended within treatment is really, really important, but it's short. It's like 10 minutes after at some point in your day. But again, remember that these are therapies that are delivered by PTs and OTs who have current BIG certification and speech pathologists who have current LOUD certification. It's important. We want to make our exercise and these exercises a lifelong habit of practice. Keep in mind those principles of neuroplasticity: use it or lose it. But in better news, use it and improve it. So if we keep exercising and we keep positive, we manage those symptoms as best as we can stay strong as possible and live a really great quality of life. Now, again, the whole goal of all of these therapies is calibration. It's helping a person use bigger movements or a louder voice for clear speech automatically in his or her or their daily living, and is able to maintain those bigger movements and louder voice and clearer speech over time. Excuse me. And these therapies, they are standardized, they're well researched and evidenced, but they're individualized. And so, though they're standardized, when you have a current certified clinician and they know what they're doing, they customize this to you as an individual. And so these are standardized programs that should be customized to the unique goals of each person. Of course, they can then be adapted or progressed to meet each patient's needs across a range of diseases, severities, and presenting impairments. So let's dig into the strategies to support visual spatial function in treatment and in daily environments. And I think these are going to be very good takeaways for you, whether you are a family member, a care partner of a person with LBD, if you are living successfully with LBD yourself, or if you're a therapist or related healthcare provider working with individuals with Lewy body. So there are specific strategies that we can use to improve visual spatial function. And ultimately, what we are doing is aiming to reduce the day-to-day difficulties caused by visual and spatial impairments in LBD. So some of these include using contrast in the environment, providing visual targets for stepping or reaching, using placemats for contrast to indicate that this is where the plate is on the larger table to indicate that that difference, that differentiation. Using glasses or dishes with color versus plain white that might blend into the background can be really helpful. And also ensuring adequate lighting is so key. And we'll talk a little bit more about that in in a minute. We also encourage minimizing clutter and visual distraction. And this is important, um, for those of you who struggle with visual difficulties, when you've got so much in the environment, it can be so overwhelming. There's too much visual distraction. We've got to think about the cognitive contributions and the changes happening. When there's so much in the background and in the environment, it can be difficult to focus. It can be difficult to have accurate visual perceptual perceptions, really, to be able to, navigate the environment safely. So minimizing clutter, reducing visual distraction are really great techniques for optimizing a person's ability to navigate things and find things in that room if they are living with Lewy body. So I talked a little bit about contrast, and this is a pretty core principle in terms of addressing these visual perceptual changes for individuals. And this can be applied to various elements, including visual documents, reminder signs, and furniture. I really like using signs that remind people to think loud and to think big, to sit big and go from sit to stand with nice bigness. And so we'll use signs that have different colors and bold type. And we might also use pictures or photos to make sure that in at different points, no matter what, comprehension is facilitated. Because when you are feeling great, or when the person with Lewy body is feeling great, that sign may be easy to read, may be easy to see. But under states of anxiety, when people feel a little bit nervous, anxious, fearful, whatever it might be, it may be more difficult to visually perceive, distinguish, and decode text. And so having pictures or photos paired with symbols or text with contrasting colors can be really helpful. Also, enhancing figure ground contrast helps objects stand out, making them easier for someone with LBD to identify. Julia, can we go back to that slide real quick? The contrast slide, thank you. But effective contrast use of contrast is essential for simplifying a person's visual experience and supporting visual or spatial orientation. Okay, so now when we get to lighting, lighting can greatly affect visual perception in LBD. And I have found this to be such an important thing to keep in mind. And also keep in mind, everyone is a little bit different. We want lighting that is balanced, not too bright, not too dim, but again, what feels too bright or too dim for you may be different for the person with Lewy body. So experimenting and being flexible is key. Something that's going to feel good and comfortable one day may not be as comfortable the next day. We may have to shift lighting accordingly. But overhead lighting can from lights. If it's too bright, it'll create a glare, and that makes it difficult to see. People start squinting and have difficulties, focusing visually. But the use of a dimmer can help the room feel well lit without too much brightness that's going to wash out what's being viewed. And again, experimenting with different lighting environments during the day and at night. This is especially important at night to be able to reduce the effects of clinical sundowning, which can increase agitation, make visual processing and perception more challenging, and make following sequential commands more difficult. And so, really being mindful of lighting at night and then shifting down to facilitate sleep and proper sleep is going to be essential. Keep in mind, you can be playing around with curtains, changing the brightness in so many different ways. But again, I can't overemphasize the importance of flexibility and checking in with that person regularly to assess change. So another effective strategy is organizing essential items to manage those things, those times when we walk into a room and we go, why am I here? What was I looking for? Or wait a minute, I know I just have that. Where did I put it? Um, so it's really key, in addition to minimizing clutter and distraction, to organize essential items. What I like to do for people is organize them in plain view on counters, in dressers, in bathrooms. I separate items in an organized way. So when people are looking for something, they can just look and easily see it. Same thing in the refrigerator. I kind of put everything close to the front. I don't put things behind items because it can be difficult to see in 3D. So just everything being able to be uncluttered, easily visually seen, and presented in an organized way will be much easier for people to look at and see. Also, keeping only the items needed on the counters every day, or in the dressers or in the bathrooms. This can also reduce visual clutter, and that's again helpful for helping people find the things that they need or identify them. Using brightly colored tape or dimensional fabric, paint dots can also help to mark frequently used objects. Setting anchor points in rooms, which is a specific spot, can be essential to help a person find their glasses, find their keys or phone. And then importantly, it can reduce frustration and make locating items easier, because when frustration and emotional regulation, behavioral regulation stays more relaxed, then everyone, Lewy body or not, has much easier access to thought organization, to their language, to the words, and the ability to physically communicate. So keeping it as calm as possible to reduce that frustration is key. And then we want to also always be mindful of adapting the environment for safe mobility. Even in familiar settings, people can have a tricky time finding things and navigating familiar rooms. So it's important to maintain proper lighting, because this also minimizes shadows and reduces that chance of visual hallucination. It also will encourage you to kind of use contrast where possible as well to minimize or increase safety. Adding simple directional signs, again with arrows to point out or indicate rooms, can be helpful. But it's also important to keep in mind that individuals who may have cognitive linguistic difficulties, in addition to other difficulties, may impact comprehension of text, as I said before. So if you're using text in your signs, make sure to pair that with a photo or a symbol to facilitate comprehension, especially in those more anxious or emotionally dysregulated times. Now, painting door frames in contrasting colors or using marked pathways can also provide additional navigational cues. And then creating unique pathways in the home. So every hallway or path doesn't look the same. It can also be helpful for helping people navigate the environment, and those navigational cues can be really helpful for also keeping someone calm so they have access to what they need to be able to be safe. You can create contrast and visual boundaries that are really easy to spot with adhesive tape on the floor or sometimes using carpet tape. But I would be very careful and cautious to just be mindful of any tripping hazards and not to create them. And then if you are an SLP that's with us today, collaborating with your physical and occupational therapist, and OTs and PTs collaborating with your speech pathologist, these are so essential, these collaborations. And if you're care partners or related professionals, get everyone talking, get everyone on the same team. That team supportive environment and consistency of care and intervention is going to be so key. And so SLPs collaborating with our PTs, our OTs, it's really going to ensure that the environment that people are functioning within is safe and supportive, identifying any needs for mobility aids or further modifications. And PTs and OTs collaborating with your speech pathologists can ensure that you're being mindful of all of the cognitive and linguistic considerations to keep in mind when thinking about safety for the person with LBD. So let's take a look at a few additional ideas that can help us with some daily tasks, focusing on organization and adaptation in the home. I want to talk a little bit about organizing closets into sections. So this is kind of an example of a hierarchical approach to targeting dressing. So for example, we could group shirts and pants and accessories separately, making it easier for individuals to find their clothing. As challenges progressed and things became more difficulty, we can place full outfits, including accessories, on single hangers to simplify dressing and keep independence strong. Labeling drawers and using visual guides such as photos or pictures or symbols can also reduce frustration, facilitate that emotional regulation. And removing rarely worn items can help people just minimize that clutter we're trying to get rid of and create a streamlined closet layout. Now, in terms of reading materials, there are great reading materials. You can buy them on Amazon or in a local bookstore that have large print and strong contrast. That's typically the most effective. Minimizing distractions by clearing off surfaces is also really helpful. And not using or avoiding glossy pages is also good because gloss can create that glare and just make it challenging to focus and read. And if it's that challenging, it's so loaded, even if it's comprehended, it's hard to remember what was read. And so using tools like rulers or magnifiers can also be helpful. If you are working with reading, what I have found to be helpful are a lot of tools made for people with dyslexia. There are great ways to track lines and track information from left to right so people are having an easier time and not skipping words or skipping lines, which increases confusion. Also, we want to consider magnifiers if we need to increase the font size within a book, if we don't have large print or technology to increase font size. And then for lengthy or complex materials, I'd consider using audiobooks or breaking down the reading into manageable sections for ease of comprehension and recall. And then also consider a book light, which can provide that direct light onto the document for better visibility. Now, when we're assisting clients, or if you are using technology and using electronic devices, adjusting the contrast and the brightness can be key to helping you make text easier to read and make your experience just more enjoyable. High contrast, you often need to set it at 100%. That's generally what is best for those with visual brain dysfunction. And adjusting the brightness is going to depend on the background. So adjust the spacing and the brightness as needed, play around with it based on the device that you're using, and then consider also adjusting space between letters, between words, between the lines of sentences, all of which can make it easier to visually track and read. And you may also consider background. I had a client at some point who liked a dark background with white text, and that felt easy for him if we also added that space. So again, everyone's a little bit different, and experimenting with settings can also help determine that most comfortable configuration for every person, allowing flexibility across devices and systems. Now, when hallucinations occur, especially if they are frightening, first, we want to quickly and gently reassure people that they are safe. So, if you are a care partner or a therapist, I want you to keep in mind that use reducing your rate of speech, keeping a gentle tone, not so loud of a volume, but enough so people can hear and understand you, making sure you're articulating clearly, and really just using a nice vocal tone to keep people calm and ensure those visual hallucinations they are seeing, they are not real and they are safe. It's important then to move to a different setting if you can, um, especially one that has more lighting or is a little bit more calming, less auditory distractions, less visual distractions, and then engaging your loved one with Lewy body or yourself if you're living with this in activities like turning on a movie or listening to some music or an audio book. All of these can redirect somebody's attention and then just make you feel better because you're focusing on something else. And then your emotions can start to regulate. You'll feel a lot better. Encouraging time spent in well-lit areas is so key during the day. Many of us tend to stay inside, and the winter's coming, so it gets cold and we stay inside, and it gets darker. It's darker earlier. And it's really important to keep those lights on during the day. And if possible, get outside, get some sunlight in your eyes. And don't look directly at the sun, but get that sunlight in your eyes, especially between the hours of 9 a.m. and 11 a.m., when it can really do a lot for setting that circadian rhythm in place that you need to be able to have good sleep hygiene and better sleep. Um, and so, um, you know, avoiding poorly dim lit areas or dark rooms other than when you're asleep is better. Um, Good sleep hygiene practices are key. Working to maintain proper day and night schedules is also important. Really being mindful as much as you can to sleep as healthy as possible. Though, as a poor sleeper, I know how difficult that can be. And then also keep in mind that poor vision can lead to visual hallucinations. And so you want to go to your doctor. If you're a care partner or a therapist, encourage that your loved one or your patient to go to the ophthalmologist and preferably an neuro-ophthalmologist to make sure that they have the right prescription and the right aids or devices as needed. And as someone who struggles with visual difficulties, I have something called Duane syndrome. And so my left eye doesn't move. It's paralyzed. It's a nerve issue. Boy, these visual difficulties can make you feel crazy sometimes. And so moving through things slowly, taking some deep breaths, knowing your strategies, keeping them in your toolbox so you can apply them as needed for yourself or for your loved ones is so key in keeping yourself calm and functional. And always keep in mind, not all strategies are going to work for everybody, at all times. And so Lewy body dementia symptoms, they're progressive. They can vary daily and with each individual. So a strategy that works one day may not work on another day or a little bit later in that same day. So regularly reassessing vision, adapting strategies as needed is essential to really meeting a person's needs and their care team's needs effectively. So to summarize, Lewy body dementia is going to impact vision in numerous ways. So staying up to date with eye care is essential. Integrating vision support strategies and exercises in everyday tasks, such as big walking or functional hierarchies in speech, can enhance patient success. Flexibility and innovation in applying these strategies are key. And so experimentation and regular adaptation is going to be what you need to help you find what works best for every person. All right. I know we're a couple minutes after the hour. Thank you so much for staying. I hope you enjoyed this presentation. Julia and I can stay on for a few minutes to answer any questions that you might have. If so, you can type your question in the QA box or the chat box in your control panel that you might see at the bottom of your screen. At the bottom of the Zoom window, you will also see a hand. And so you can raise your hand, we can unmute your mic and have you ask the question out loud. And if you would prefer to ask us a question later, you can email the email address here or on the next slide. You'll see a few different email addresses. One is webinars@lsvtglobal.com. And also there is an info@lsvtglobal.com. You can email questions to as well. After today's webinar, we're going to have a survey that will just pop up right on your screen. It will also be emailed to you tomorrow. And you can find the link to the survey below the webinar description for each individual webinar if you're also looking for or viewing this webinar on demand. So you'll see that also LSVT Global has launched a podcast. The next episode is episode 6 with Dr. Jory Fleischer, who's a wonderful movement disorders neurologist at Rush University Medical Center. And she's providing and giving an excellent lecture on empowering care partners and caregivers in Parkinson's disease and Lewy body dementia. So we're excited to hear about the insights from her Persevere study at Rush. So thank you. Here's that email or that email address I mentioned, info@lsvtglobal.com. And if we've gotten you interested in any of the therapies, or if you're looking for an LSVT BIG or LOUD therapist that's certified in your area, go to lsvtglobal.com and you will find a place to find a clinician in your area. So thank you so much for joining us this afternoon. It's really been such a pleasure. Julia, do we have any questions? Let's take a look. Candy is looking for a handout to the webinar slides. And so Jessica, if you don't mind putting, there you go. Perfect. We've got that for you, Candy. I hope you're able to open and access. And then I see we've got one other question. Is there a program for care partners to follow to help people doing LSVT even after the program ends, just so the skill remains? So it's a great question. It's something that your therapist should be training you to do during that program. And so when your providers are doing LSVT big or loud with your loved one, um, you might ask to sit in on one session. You may ask for, information about that home exercise program and how to best cue that individual, which may vary across the weeks of therapy and then for maintenance. So make sure, ask your therapist, this is something they should do for you. And many individuals or practices, including my own, provide specific training for care partners involved in caring for a loved one who's done LSVT loud. So be on the lookout for that as well. And then what Julia just posted into the chat was a really great diagnostic symptom checklist. And so you can click the link there and you'll be brought to the Lewy Body Dementia Association Diagnostic Symptom Checklist, which is a really great resource for kind of walking you through the different symptoms that one might experience at different times, so you're not so surprised. All right, Julia, anything to add, or do you see questions that I don't?
I'm going to put some links here in the
Great.
chat for you all if you're interested in more resources on vision. Well, I thought I was going to. Hold on. So we have a great resource at LBDA on visual function. We had a very lengthy webinar a couple of years ago where we had a neurologist who's a movement disorder specialist, a neuro-ophthalmologist, we had an optometrist and an OT all talking about all of this. So that is available too in the links that I'm going to try to get on here for you. So if you have any more questions, feel free to reach out. Even if you reach out to LSVT Global, they can forward you to me if needed to, because we know that this is something that a lot of people have a whole lot of questions.
Yeah. All right,
Absolutely.
great.
All right, let me see if I can get these links in here. For some reason, they're not pasting. I will send out, I suppose, that list, and they can send it in the follow-up email.
Terrific. And as
What's
you're
going
doing that, Julia, I have another question from Ryan, who has a fair share of clients in Singapore who do not have the financial access to see both PT and speech. And so he's wondering, should he, a physical therapist, attend LSVT LOUD to access some interventions to implement? I wish I could say yes, Ryan. I think, in the same way that we would love to provide big to some of our patients who can't afford to do both. Um, unfortunately, we just don't have the background or the skill sets to do that safely. We are still working with respiratory voice and cognition and swallowing. And so, um, you know, um, encouraging big amplitude is good. Encouraging that loudness when you're doing some counting with some repetitions and movements is good. But trying to find organizations or institutions that provide sliding scales, discounted services, services via scholarship. There are so many really interesting, unique ways that people are getting access to these services. So reach out to us. We'll help you find creative ways to help your patients not only receive LSVT big, but loud as well. Good job, Brian. Keep going.
Excellent. All right, it looks like that's all of our questions, I believe, unless anything else has come in. So I
I
think
think
we
that's
got them
it.
all.
Okay,
Yeah,
terrific.
thank
Well,
you
it's
all so
been such a
much.
pleasure. Yeah, yeah. So it was such a pleasure. Julia and I have had a wonderful hour with you. I hope you've gotten a lot out of this. For those of you who have more questions or questions later, again, don't hesitate to reach out. We are a resource for you. We are here for you. And we'll do our best to get the information that you're asking for if we don't already have it. Have a wonderful rest of your day. And thank you again for joining us. We will see you soon at the next webinar next month. Take care.
Thank you all. Thanks, Jessica.